to the new Retina Radio Journal Club with VBS. My name is Christina Weng. I'm on faculty at the Baylor College of Medicine, and it is a true privilege to be serving as the moderator for today's discussion. We've chosen two great papers, and I would like to take a moment to introduce my esteemed panelists. First, we have Dr. Brian Doe from the Retina Group of Washington. Hey, Brian.
Nice to see everybody. Thanks for having me.
And then Dr. Mrinali Gupta from Retina Associates of Orange County. Hi, Mrinali.
Hi, Christina. Looking forward to the discussion.
And last but not least, Dr. Dimitra Skondra on faculty at the University of Chicago. Hey, Dimitra.
Hi, Christina, and the rest of the group. Looking forward to our fun chat.
So for those of you who might be tuning in for the first time to New Retina Radio Journal Club, this is a really fun way to discuss some of the latest high impact papers that have been published. And again, it's a very special edition because it's not every day you have one of the lead authors involved as a panelist on the paper that we're going to talk about. And so the first paper we're going to discuss today, Dimitra Skondra is the senior author for. This is a paper by Jared Sokol and colleagues on medical treatment for macular holes. And so it's called Macular Hole Closure with Medical Treatment. It was published just a few months ago in Ophthalmology Retina. And then Brian Doe is going to cover a very similar paper. It's called Treatment of Secondary Full Thickness Macular Holes with Topical Therapy that was published last year also in Ophthalmology Retina. So I'm going to kick things off to Dimitra first to give us a summary of her paper and her work.
Thank you, Christina, and thanks for the opportunity to present our work. It easily took a lot of people to put this together, and I think it's an interesting paper, and hopefully you will enjoy the discussion. So our paper is basically a multi-center retrospective observational case series of 14 patients that all underwent successful topical medical treatment for full thickness macular holes. And the treatment involved all of them with what we call the triple therapy. So they had a steroid drop. Most of them was a prednisolone acetate every 3 to 4 times a day, or difluprednate, durezol every 2 or 3 times a day. They also, all of them received the treatment with non-steroidal anti-inflammatory drop. Most of them ketorolac, but some of them also got bromfenac. And also all of them were treated with carbonic anhydrase inhibitor, most of them brinzolamide and a good amount with durezolomide. 2 to 3 times a day. So the mean age of our patients was what we expect for a macular hole cohort of about 6 to 7 years of age. And actually these seem to be small holes. So again, I repeat, these are holes that all had successful closure with the drops. And the mean size was about 166 micrometers, plus minus 15 micrometers, with the range up to upper 200 microns. All eyes had the cystoid macular edema or macular cystoid hydration on OCT, and half of them had previous vitrectomy, while half of them were actually idiopathic macular holes. They never had a vitrectomy before. So what we saw when we put these patients in this regimen, and then we watched them closely for a few weeks, is that within 2 to 4 weeks, the majority of the patients presented with an improvement in the CME and some changes in the size of the hole. But first, it was like the changes that we noticed in the CME surrounding the hole in the OCT. And then from a range from 2 to 8 weeks, within mid duration of 5.6 weeks, the hole closed in most of the eyes and the vision improved. The treatment duration really varied. We had a couple of patients that kind of lost follow-up, so it's hard to tell exactly when the hole closed because they did not come as expected. But overall, there was a range from 3.5 months to up to 20 months of duration. And I think part of the range is because this was a multi-center study, so each of us did not have a standardized way of how we taper the drops. And we kind of did a different kind of taper per patient and also per physician involved. The vision acuity at presentation was at mean at 2070, and it improved to 2040, which was very statistically significant. Regarding some adverse events or safety, in 2 of the patients, the macular hole opened again after the patients were weaned off the drops in about 6 months or more. And actually in one of them, they closed again with drops, and 2 patients develop worsening of the ERM and have to undergo vitrectomy for ERM and membrane peel that caused the persistent macular edema and persistent hole. We likely did not have a lot of issues with the pressure. Some patients could develop some mild ocular hypertension that responded very nice to topical therapy and actually was not persistent after the stopping of the steroid drop. So in conclusion, it seems that full thickness macular holes in a small size, probably around 150 to 200 micrometers, may benefit from a dropped regimen in this case. And this could be eyes that either had vitrectomy before or is idiopathic macular holes, and they had systolic hydration, no vitreomacular traction, and they can have a little bit of a mild DRM, but without significant tractional component. The mechanism is not really known, cannot tell, but the speculation is that the drop treatments may increase the fluid absorption via the RP pump.
Thanks for that terrific overview, Dimitra, and great work. I'm going to now pass things over to Brian, who's going to talk through the second paper by Niffenegger and colleagues. Brian.
So the paper that I'm going to discuss was also a retrospective case series. It was written by Niffenegger and colleagues. Similarly, a small number of cases. They looked at 9 eyes with full thickness macular holes in 8 patients that received topical therapy. Interestingly, they sort of differentiated between secondary and primary macular holes. Secondary, they referred to as folks who seem to have developed macular holes for reasons other than the typical mechanism of anteroposterior vitreofoveal traction. So in terms of treatment, all eyes received difluprednate drops topically. 6 of the 9 eyes also received topical carbonic anhydrase inhibitor. 2 eyes were prescribed NSAIDs, one of whom experienced elevated IOP and keratopathy, IOP presumably due to the difluprednate and keratopathy due to the NSAID, but all that seemed to get better when they sort of pulled back on the drops a bit. Among the 9 eyes, 6 patients had prior retinal detachment, 3 of which had been treated with scleral buckle, 1 with vitrectomy, 1 with pneumatic retinopexy, and 1 with barrier laser. 3 of them had previous vitrectomy, 1 for retinal detachment, which we discussed in the group of 6 RD patients, 2 for epiretinal membrane. And there was 1 remaining patient who had a history of vitreomacular traction and a history of blunt trauma. At the time of initial diagnosis, all 9 eyes had some element of epiretinal membrane and cystoid macular edema. So the average initial macular hole diameter was about 80 microns, ranging from anywhere from 44 microns to 132. Average follow-up for these eyes was about 53 weeks, and amongst the 9 eyes that were discussed in the paper, 8 achieved successful hole closure, CME resolution, and improved visual acuity after a mean of 6 weeks. Average visual acuity prior to treatment was 2100 and improved to a mean of 2050 at the end of the treatment period. Interestingly, 1 eye experienced hole reopening upon discontinuation of treatment during the follow-up period, but the hole closed once treatment was reinitiated.
Great. Well, thank you so much for that terrific summary, Brian. And we're going to just ask Mrinali for some impressions of both of these papers to start off with. I think all of us here love doing surgery. We love being in the OR, but can all agree as well that all else being equal, a medical treatment is always preferred over taking somebody to the OR, especially over the past year and a half with the pandemic where there's been more limited OR time. So it's neat to think about treating what's classically been a surgical disease with potentially a medical treatment. Mrinali, what were your initial reactions to the paper? Do you think this is a real effect that we're seeing, or do you think some of these macular holes may have closed spontaneously on their own, even without drops?
Great summaries, Dr. Skondra and Dr. Doe. I think that the paper is very interesting to me for a couple of reasons. One is that we've seen case reports here and there of these holes closing with medical therapy, but I think these 2 are although small, some of the larger retrospective series of medical topical therapy for full thickness macular holes. The take-home points that I noted were that these are very small holes. They all tended to have cystic changes, of course, at the edges of the holes and no obvious tractional components. I think it drives home the point that macular holes are more complex than we may have previously understood. It's not just a mechanical tractional thing happening, but some of these eyes may have a tractional component. Some of them may have a hydration-related process going on and dehydrating the edges of the retina and getting the cystic plate spaces out might help close these. Some may have a combination. A lot of these in the paper that Dr. Doe summarized, they were all secondary macular holes. And I think half of the ones in Dr. Skondra's paper were secondary. So they may have already had at least the hyaloidal traction removed during the vitrectomy, a lot of these, and some may have also had ILM removed during the ELM peel or prior MAC hole surgery and things like that. So something I would think about even more so in a small secondary macular hole with cystic changes. But as you know, some of these holes, they're very small holes, might have closed on their own. And so it would be interesting to see some prospective studies comparing these two regimens, even if it's scheduling patients out for surgery 2 months from now and watching what happens in the treatment group while you wait surgery. And if they don't close, take them to the OR anyways.
Yeah, great points, Mrinali. Thanks for sharing. Dimitra, I'm going to ask you, Brian Doe gave a great summary of the Niffen-Nager paper. Do you feel like that paper corroborates what you and your group found? Are there any distinctions between the papers that you want to point out?
Thank you, Christina. And I agree, Brian did a great job presenting the other macular hole paper. I think it's very encouraging that two separate studies from two different groups kind of addressed and presented the results. And actually the results were kind of similar in the sense it was small holes with macular edema. The mean duration was about 5-point-something weeks in both studies. And there was a range. There are some small differences. The paper that Brian presenting were all secondary holes that they already have a retinal pathology. Not all of them with vitrectomy that the hyaloid is removed. While in our case, half the eyes were idiopathic macular holes without previous surgery, without vitrectomy, and half of them were secondary that potentially there may be a more prominent inflammatory component. Another thing that I would like to make a note about this is like the size of the holes in our study was slightly bigger, which I think is encouraging, that it doesn't have to be a super, super tiny hole to be responsive. The average size is double than what they found in their study. And actually in our case series, some of the holes were like in the mid to upper 200s. Also in our study, we always use the 3 drops. Maybe it's not needed because they had very good outcomes just with 1, sometimes 2 or sometimes 3. But for that, definitely we need to do more prospective studies. But I think the fact that idiopathic small holes closed, these, I think that's the ones that were like, cannot tell for sure it was spontaneous. And that's why we need prospective studies. But I agree with Mrinali that and I do it now, that I've seen what I call the characteristics of potentially good candidates. For me, that was the main point of publishing the study. Obviously, it's not the proof, but it's kind of like, okay, if someone's going to be a candidate, it's more likely it's going to be these characteristics to identify good candidates going forward, either for a prospective study or from a clinical practice. So everybody with a small hole, I have a very honest conversation with them. There is no standard of care that it may delay the treatment for a few weeks. And within 6 weeks, you have an idea if there's no response. And so far, those that have not responded and I took them to surgery, they all had excellent outcomes. So I don't think that we really detriment the outcome by delaying a few weeks for macular hole cases. Just since the paper was published and that, I have several cases now that kind of like more proven that the drops doing something, that the holes opened up when we went off the drops, and then I put them back on the drops and they closed again, and then they opened up again, and then I closed them again with drops. So, the fact that whenever you stop the treatment, it kind of like goes away. And some of them are actually idiopathic, which is to me very surprising that it's not so clear postoperative late onset edema. But I think it's worth as a community to put forward a prospective study targeted at these potential good candidates.
Well, great comments, guys. Looking forward to a more in-depth discussion on both papers right after this quick break. Stay tuned. Welcome back to the new Retina Radio Journal Club with VBS. I'm Christina Weng, and I'm delighted to be joined here tonight by Dr. Brian Doe, Dr. Mrinali Gupta, and Dr. Dimitra Skondra. Thanks for sticking with us. We're now going to move our discussion towards a more clinical relevance focus to the 2 papers that we discussed earlier. So I'm going to start off with asking Brian, as has already been mentioned several times, these holes were small. They were on average 166 microns in Dimitra's paper, and actually not even 80 microns in the Niffen-Nager paper that you so eloquently summarized. And half in Dimitra's series actually had a prior pars plana vitrectomy for either a retinal detachment or a full thickness macular hole previously. So that changes sort of how you may contextualize the results. Do you think, Brian, that the fact that the hyaloid and ILM, which have already been removed in a lot of these cases, helps to facilitate and maybe increase that level of success with topical drops? What do you think about that?
I suspect so. I'll just comment that, at least in the Niffenegger paper specifically, they didn't necessarily comment on the status of the hyaloid in terms of attachment at the macula or fovea. And I think that's especially important when you're looking at cases like, ones that have undergone scleral buckling without vitrectomy. In which case, I don't think of the mechanism as very different from what we traditionally think of in idiopathic macular holes. That being said, from a theoretical standpoint, I think removing the vitreous probably does something to the ability of these medications to concentrate within the vitreous cavity, and the concentrations of these medications just directly overlying the macula. There might be some impedance to the medications making their way back there in an eye that still has its native vitreous. And an eye that's had its ILM removed, theoretically, there should be much less tangential traction, sort of holding the edges of the hole open. And so, if you have that combination of, potentially a greater dehydration of the sort of peri-hole macula, as well as, less tangential traction, I think there's potential for success.
Yeah, that's a great point. I really like how you highlighted the fact that the proposed mechanism of using a carbonic anhydrase inhibitor is the dehydration component, which is interesting because we saw that a lot of these holes indeed had a presence of cystoid macular edema. I'm curious, throwing it out to the group, who's tried this? Obviously, Dimitra has, but Mrinali, Brian, have you done this in your own practice? And what specific characteristics are you generally looking for in a patient with a macular hole who you'd be willing to try this on?
I have tried it on a few patients. One of them closed and we were able to cancel surgery. Typically, I book the surgery and I start the drops and I see them and tell them if it doesn't work, we already have something on the schedule. And if it does, we'll cancel the surgery. And one of those patients ended up closing and remained closed afterwards. I think just as the study suggests, smaller holes and holes where you see cystic changes and you don't see the hyaloid creating a lot of VMT or a big ERM contributing to the macular hole are more likely the ones that might benefit from this sort of approach.
How about you, Brian?
So I know Dimitra was hoping that we'd all have some cases to contribute to future series. And I'll admit that I have tried it in a handful of patients. I don't think I can recall a case while in practice of a macular hole any smaller than 300 microns. So similarly to Mrinali, I'll book patients out for maybe 6 weeks, depending on how long they feel like waiting. I oftentimes have patients who don't necessarily want to jump into surgery directly and don't mind the idea of trying something less invasive first, but unfortunately have not had any success personally.
All right.
Well, if they're about 300, I'm not surprised.
So Dimitra,
I'm just unlucky, I guess.
Dimitra, I wanted to ask, so I've had one case personally that I offered. It was a patient with a small full thickness macular hole, less than 250 microns. And we had actually signed him up for surgery. And I said, you know what, we can just try this. I actually printed out the abstract of your last paper and gave it to him as well and said, in the meantime, why don't we give this a try? I'll see you back in a few weeks and we'll go from there. And obviously we will continue working on the scheduling of your surgery in case it doesn't work and you still need to proceed. And he was very pleasantly surprised. I was very pleasantly surprised that in that case, the patient did close and we avoided a surgery altogether. So it's great to have that option. I think we probably need to learn more about specifically what characteristics are going to optimize the chance of success in patients treated this way. But I wanted to ask you, one thing I was troubled with in that patient is once that hole closes, how do you go about the taper? Do you taper right away? Do you kind of draw it out for a little longer? You referred to this a little bit in your summary in that some holes reopen and then have to be closed again with the drops. Talk about that.
So this is something, obviously there's no answer and it's kind of like an instinct and you go by case, but typically I keep them in all 3 drops until I see a resolution of the edema. And once I see resolution of the edema, unless I have like any very high pressure that doesn't respond to drops, which I have not really seen. If I see a pressure spike, I add a drop or two because I know eventually I'm going to taper them off. And once I see the edema resolve, and sometimes you see this like persistence of retinal fluid, that can take a long time to go away. So if they don't have a pressure issue, I'll keep them on all 3 drops until the little subretinal fluid goes away. If they start having pressure issues, I'll cut down on the steroid and keep them at the 2. And let's say all the fluid is gone, all the hole is closed, Then I try to taper one by one, because we don't know yet which of all the 3 drops actually is important. And maybe some cases more of the azote, because they want more of the pumping effect. In some cases, be more the inflammatory component, especially the secondary holes. So the steroid or the ketorolac are more important. So I start always the steroid first, because it can give the pressure issue. So I'm more comfortable having people on the NSAIDs and azote for months rather than being a steroid for months. And then I do like a slow taper every couple of weeks. And then I watch them very closely. If I see the swelling come back, or I see the hole about to open again, I may put it back on and maybe try to taper another drop. So it's really how the patient responds, but I don't drop all of them at the same time. I do a slow taper. I start with the steroid, and I start the taper after I see the swelling be gone and most of the subretinal fluid to be gone. Another caveat I want to say is that, yes, most holes close on a mid-duration about 5.6, but there are some holes that actually it will take like 8 or 10 weeks to close. And I think the mistake I've seen in some patients that came to me and they already got surgery, and when they asked me to look at their scans, is that they already had an improvement. Like if you look at the serial OCTs, you'll see the swelling get better, you see the cyst getting smaller, and even the hole of the size getting smaller. So just because the hole is not closed in 4 or 5 weeks doesn't mean it won't close. If there's no change in 4 to 6 weeks, I rarely see improvement afterwards. But if you see less edema, some vision of the improvement, the whole diameter, the whole size may or may not close, I think still give it a few more weeks and just always have like a date so you don't delay the definite treatment. But OCT angiography and fast is a great also tool to get an idea how the cysts respond, because with sections it's hard to always tell. But when you go to these unfast pictures on the OCTA and you can see actually the cysts, you can get an idea that the cysts getting smaller, you get less cysts, even though overall the whole looks about the same.
Yeah, great summary. And so just to kind of recap for the audience, a slow staggered taper, perhaps when the hole closes, and also don't be too impatient and jump into the OR too quickly. You might need up to 8 to 10 weeks with these topicals before proceeding with vitrectomy. I think those are great insights. Mrinali, I want to ask you a little bit, usually when we talk about medical therapies, we don't get as nervous about safety issues, especially in drops that have been well established and part of the regimen for a lot of different diseases. But are there any concerns about the keratopathy that can happen with NSAIDs, which were used in a lot of these regimens, or the elevated intraocular pressure that can happen with topical steroids? Talk about the safety issues for a moment.
Great question. I think that, as we all know, every intervention, not doing anything, drops, injections, surgery, they all have risks. I think in general, I would consider the risks of the drops to be far less than the risks of surgery, especially because the pred component, I'm going to give them anyways for at least a short period of time after surgery. But yes, of course, the steroids can cause a steroid response. I find that almost always responds really well to topical agents, and you can taper the steroids off. Keratopathy is a concern in NSAIDs. Also, generally reverses pretty well. You might need to put plugs in or do more in some cases, but generally reverses well in eyes with NSAID-related keratopathy, unless there's something else going on like PUK or something like that causes a melt, which of course you would know beforehand. So overall, I think it's far safer than surgery. The other thing I do wonder about though is if you wait 8 or 10 weeks and they don't close and then you schedule the surgery, is that delay going to impact their outcome? Or in these eyes where you close the hole and then you taper the drops and it opens back up and then you close it, is that opening and closing and that protracted process impact outcomes? I think the prospective trials will be helpful in understanding that a little better.
I thought about that exact same point, and I almost equate it to like a pneumatic, right? That you might perform before taking a patient for surgery for retinal detachment. You want to know if a failure or delay in care has any sort of negative impact on ultimate visual acuity. I think that's a fabulous question. Brian, I'm going to give you the last word here. Thinking about the limitations of these 2 case series, what other data would you want to see when it comes to using topical therapy for full thickness macular hole? What would help make this more convincing?
I think we've talked about it already, but seeing some prospective data in macular holes of various sizes, maybe even stretching outside of these smaller macular holes, I don't see why, it wouldn't be possible for some slightly larger holes to close as well with pharmacotherapy. We've talked as well about the likelihood that, these holes might have closed with conservative observation and in the absence of treatment. I don't know the exact numbers myself, but maybe, the holes that fall within these size ranges make up, 4 to 11% of macular holes at large, which could mean that, many of them would have closed on their own without treatment. But again, I think as with anything else, prospective data would be helpful. What's convincing to me is, the few cases sort of aggregately from the two papers that reopened upon discontinuation of treatment and then closed again once treatment was initiated. So certainly there's some merit to, at least I think there is, this type of treatment. We just have to see whether or not it's applicable to a larger population.
Yeah, absolutely. Well, really interesting paper. Congrats again to Dimitra and her colleagues for this excellent work, and look forward to seeing more data in the future. I want to take a moment as we wrap up to thank Doctors Mrinali Gupta, Dimitra Skondra, and Brian Doe for their excellent insights on today's Journal Club. It's always fun chatting amongst friends. And thanks to all of you who are listening and tuning in to New Retina Radio Journal Club with VBS. We hope that you learned something new today. And don't forget to stay tuned for future episodes.